We are now going to analyze the anterior surface of this ankle and tarsus. When a patient has a talocrural pathology, they always say the same thing. I have an arciform pain in the anterior part of my talocrural joint. Not really. They will actually just say, I have pain in my ankle. In any case, we are looking for a synovitis, an effusion, or an osteochondromatous nodule embedded in the anterior recessive. We make a sagittal section that will pass through the articular capsule. We can clearly see it here. It closes this dorsal recess with here the dome of the talus covered with its cartilage, and here the distal epiphysis of the tibia. We look for fluid in this area, but when the foot is in this position, the fluid is sometimes expelled posteriorly. To see it, Dr. Bourdet taught us a very practical trick, which is to press the pre-Achilles space here and find out if there is fluid distension during this maneuver. Then naturally, we continue on the dorsal talonavicular ligament, especially with a sprain. But in other cases, there are two main things to consider. One is the bony contours, because many patients have osteoarthritis problems in the region of their medial tarsal joints. The second is the Chopart joint, and this osteoarthritis, which will lead to dorsal synovial swellings or small synovial cysts that are painful to palpation. And so when we see a hypoechoic pathology or an electively painful focal irregularity, we can make the connection between the osteoarthritis detected on the lateral side of the foot and the patient's symptomatology. Then let's move to the tendons. There are 3 tendons, sometimes 4, on the dorsal side of the foot. Let's start with the most prominent, the anterior tibial tendon. This very superficial tendon is a trap because its 2 main pathologies are poorly described by the patient. The first is the rupture of this anterior tibial tendon. This rupture usually occurs in elderly patients following mild trauma and does not prevent dorsiflexion of the ankle. This is why this rupture goes unnoticed. In addition, in the event of a rupture, the patient often presents for a mass corresponding to the retracted tendon that becomes stuck under the extensor retinaculum. The patient does not come in for a rupture or pain, but for a mass syndrome located on the anterior medial side of the ankle. This is the first pathology of this anterior tibial tendon. The second pathology is also a trap because it involves the insertion of the anterior tibial tendon on the cuneiform. We start from a place where we can easily see the tendon and slowly descend to its attachment on the wedge. In fact, the tendon is bifid at this location, but on ultrasound, it's difficult to separate the 2 portions. But observe that we are at the insertion of the anterior tibial tendon on the cuneiform, and look at the position of the probe. We are bluntly medial, and in cases of enthesopathy, the patient complains of pain radiating to the arch of the foot when it is caused by a dorsal tendon. However, the pain on palpation, the reactive vascularization on Doppler, and the hypoechoic swelling compared to the opposite side prove the very frequent distal enthesopathy of this anterior tibial tendon. The second tendon is the extensor hallucis longus. To locate it and be certain, it is best to start from the anterior tibial tendon, which is the most medial, and then the first tendinous structure that we encounter beyond that is the extensor hallucis tendon. It is the one whose muscle descends most distally. Then we gradually follow it until it inserts on the base of the second phalanx of the hallux. Yes, it's not very easy to keep the probe in contact with this tendon, but we can do it by keeping our fingers on the patient's skin and going very slowly. Then it must also be studied in the axial plane because its main pathology is tenosynovitis, which causes a hypoechoic halo. It is sometimes seen around the anterior tibial tendon, but often around the other two tendons. We see that the extensor digitorum longus muscle is the one that descends the lowest. This is the anterior tibial tendon and the extensor digitorum tendon. We follow it very gently distally in search of a hypoechoic tumefaction, testifying to a surrounding tenosynovitis. We also see the relationship between this tendon and possible osteophytes on the dorsal side of the tarsus. Then we go up a little toward the leg, and we find here a structure that we can see very well in this patient. It is the superior retinaculum of the extensors. We see that these extensor tendons are pressed against the tibia by this fibrillar structure, which is a thickening of the crural fascia that comes to press these tendons against the tibia. Otherwise, with each dorsal flexion of the ankle, there would be a gap between these tendons and the cortex, with tendons protruding under the skin. There are small ramifications that surround these different tendons. In the normal state, as here, they are barely visible, but in cases of pathology, they can thicken significantly. So the anterior tibial tendon, the extensor hallucis longus with its large muscle, and here the extensor digitorum longus. We see the superficial retinaculum and can follow it until its insertion on the fibula. It can frequently tear here and also complicate an ankle sprain by this tear. Back to the tendons. We follow them distally. Here we see the neurovascular bundle with the deep fibular nerve. And here we have the extensor digitorum longus. Watch as this extensor digitorum tendon splits into several branches that become very superficial and line the single muscle on the dorsal side of the tarsus, which is the extensor digitorum brevis. We see these are very superficial small strips, extremely vulnerable to a blow from a crampon, for example, or other objects. We go back slowly to show another structure. We are here at the level of the tarsus and no longer of the leg. Here we find the inferior extensor retinaculum, which surrounds the extensor digitorum longus. It sometimes inserts into the lateral malleolus. If we go up, it merges with the superior retinaculum, but the inferior one is inserted at the location of the sinus tarsi by surrounding the extensor tendon like a sling. Then it literally plunges into the sinus tarsi where it will insert. This inferior retinaculum also extends to the dorsal face to come here to tie the other extensor tendons opposite the tarsus and plate these extensor tendons against the tarsus. This patient does not have a fibularis tertius, so he does not have the fourth tendon that we can see in some cases. A fibularis tertius would be even more lateral and come to insert on the fifth metatarsal. So on the dorsal side, there first is the articular plane with the talocrural articulation and with the transverse tarsal and mediotarsal articulations. Then there are the tendons, the anterior tibial tendon, the extensor hallucis longus tendon, and the extensor digitorum longus. Then there are the two retinacula, the superior extensor retinaculum and the inferior extensor retinaculum, which is reflected around the extensor digitorum longus before dipping into the sinus tarsi.